First of all, I would like to thank you for giving me this great opportunity to speak at this conference, and just give me a second just to upload it, please.
And I request you to turn on the video, doctor. We cannot see.
Oh, sorry.
Yes, perfect.
Is it clear to everyone?
Yes, doctor?
Okay. Shall we start?
Yes, please.
Okay, thank you. So I would like to present this a case report of isolated umbilical cord cyst in the second and third trimester. About the history of this patient, this is a 35-year-old lady who is gravid 6 para 3, all spontaneous vaginal birth, and this was a IVF pregnancy due to a secondary infertility, and this is with the new partner. The patient had a regular antenatal visit, and her vital signs and physical assessment were unremarkable. She was not in any medication and doesn't have any medical, surgical, or family history of significance. Her BMI was 30. About the investigation done for this lady, all blood tests were normal, and the ultrasound scan showing a single viable fetus with normal liquor and the upper anterior placenta, and she was 20 weeks gestation at that time. And during this scan, there was a cyst in the cord surrounding the umbilicus, measuring 52 by 40 millimeter in diameter. And the cyst has a homogeneous ecotexture and resembled the amniotic fluid. It was about 1 centimeter apart from the umbilical artery, and the umbilical vessels were seen normal, and no apparent congenital anomalies seen during this scan. This is the, if you can see here, this is the umbilical cord, and you can see this, the black area here where the umbilical cyst here, and this is another view for that cyst. And here the Doppler were the blood vessels, the umbilical vessels, and here the black one here is the cyst. So the patient was referred to the fetal medicine for a detailed anomaly scan, and congenital anomalies were ruled out. Karyotyping and chorecentesis were not recommended as she was not associated with the congenital anomalies, and the plan was for 2 weeks antenatal scan to monitor the fetal growth and to check for any IUGR or abnormal umbilical artery Doppler. So the case discussed with the MDT, and the patient opted to have a vaginal birth unless there is something emergency for the maternal fetal cause of the cesarean birth. So at 39 weeks, the patient went into spontaneous labor. However, it was ended by emergency cesarean birth due to the fetal distress. The baby cried immediately after birth, and baby weight was 3.1 kilogram and looked healthy with no apparent congenital malformation. The neonatologist, they were there at the time of the birth, where they reviewed the baby and they requested abdominal, pelvic, and bladder ultrasound, and all came normal. The patient was discharged from the hospital, and the baby was followed up after 4 months with no complication, looked healthy. So this is the photo of the cyst here. About the importance of the umbilical artery, the umbilical cord is the vital connection between the fetus and placenta. By week 7, the umbilical cord has fully formed, composed of the connecting stalk, vitelline duct, and the umbilical vessels. The umbilical vein carrying the oxygenated blood with the nutrients from the placenta to the fetus, and the umbilical arteries transporting the deoxygenated blood with waste product from the fetus to the placenta. The umbilical cord composed of two umbilical arteries and one umbilical vein surrounding by the gelatin-like extracellular matrix known as Wharton's jelly. And this for the circulation, for the placenta to the baby. About the abnormalities in the umbilical artery, there are several abnormalities that can be recognized in the umbilical cord and may affect the pregnancy outcome, especially neonatal outcome. So the classification for these abnormalities, there is some structural or morphological anomalies or anomalies leading to the cord compression or conditions of the histological cord pathology. In the structural morphological anomalies, such as single umbilical artery or persistent right umbilical vein, marginal or filamentous insertion of the umbilical vessels, vasa brevia, cord varix, cysts of the umbilical cord, aneurysm of the cord, abnormal coiling, and anomalies of the cord diameter or length. Regarding the anomalies leading to cord compression, such as the cord entanglement, knots in the umbilical cord, cord prolapse, and condition of the histological cord pathology like the phenocystis in case of the chorioamnitis and meconium-associated damage of the umbilical cord. Here, there's some few cases were diagnosed during the second trimester, and some of them associated with normal neonate, and the others with the IGR with polyhydramnios, and others with also moderate polyhydramnios and suspected IGR. So this is few cases I've collected for the second trimester with the different outcome, and others with the some heart problem like the VSD and IGR. So the etiology of umbilical cord cyst is unknown. It can be easily recognized by the ultrasonography at various stages of gestation. And the umbilical cord cysts are either true cyst or pseudocyst. The true cysts, they are derived from the embryological remnants of either the allantois or the omphalomesenteric duct, and are located typically toward the fetal insertion of the cord. Regarding the pseudocysts are more common than the true one and can be located anywhere along the cord. The cyst can be multiple or single. It can be also central or located near to the fetal or placental insertion of the cord itself. According to the several studies, there might be an association between the morphologic characteristics of the cord cyst and the risk of the fetal abnormalities. There is no increased risk of recurrence of umbilical cord cyst in isolated case, while in case of the trisomies, the recurrence is about 1%. If they grow and persist, they potentially endanger the fetal restriction blood flow through the umbilical cord, either through the compression or thrombosis. And I think this is what happened in our case, where she was complicated with the fetal distress during labor due to the compression of the blood vessels. So the umbilical cord cysts in different trimester. So this is according to the trimester, it is either in the first trimester detected or during the second or third trimester. So in the first trimester, the prevalence is 0.4% to 3.4%. However, in the second or third trimester, it is unknown. It is a rare sonographic findings. The association usually in the first trimester, it is isolated. It may be physiological findings in the development of the normal umbilical cord. In the second or third trimester, it is associated with the chromosomal abnormalities, include the trisomies 13 and 18, as well as structural defects such as omphalocele, tracheoesophageal fistula, and imperforated anus. The follow-up in the first trimester, many of the first trimester cysts disappear by the second trimester. And the second or third trimester, detailed investigation for additional information is needed to exclude any trisomies or IGR associated. The prognosis for the first trimester umbilical cord cyst, if resolves, carries good prognosis. And in the second or third trimester, when isolated, there is no relation between the prognosis and gestation weeks at diagnosis. As a conclusion, the presence of congenital anomalies associated with the umbilical cord cyst should lead to further detailed sonographic evaluation in the tertiary center. When either the IGR or other anomalies are found, karyotype testing is recommended to exclude any genetic disorders, as we mentioned that the trisomies 13 and 18. The accurate evaluation of the fetus, placenta, and the umbilical cord is now possible by the widespread use of the high resolution of obstetric ultrasound. In case of isolated cases, there is no increased risk of recurrence of the umbilical cord cyst, and performance and accurate evaluation of the umbilical cord during the routine ultrasound examination is essential just to detect if any abnormalities. So the recommendation was the comprehensive training and hands-on practical sessions are essential to equip obstetricians with the necessary skills to perform obstetric ultrasound effectively. Detailed ultrasound for the patient diagnosed with the umbilical cord cyst, and fetal karyotyping for non-isolated cases. And consider referring to the FMU to confirm the diagnosis, and we need to involve the MDT and the presence of neonatologists at the time of birth, just to check the baby. Thank you. And mortality for gynecological cancer patients from 2022 to 2023. It was done in the Hywel University Health Board. So the aim of this audit was to review our performance at the Hywel University Hospital concerning the surgical morbidity and mortality for gynecological cancer patients. The primary aim is to assess our performance against the established benchmarks and identify areas for continuous improvement. And this period covering from March for this patient collected from March 2022 to March 2023. Our standard was the National Optimal Pathway for Cancer and the network modified Clavin-Dendo classification. And this is classification. I'll discuss later about this one, but however, this one for the surgical morbidity outcome from the cancer patient. So the diagnostic pathway, including the staging, should be performed within 28 days from the point of suspicion, and the definitive treatment commenced within 21 days from the decision to treat. Meet the suspected cancer pathway waiting time of 62 days for the patient presenting with the suspicion of cancer. And it is recommended that following the suspected malignant finding at hysteroscopy, patient should be having the CT tap for the thorax, abdomen, and pelvis, performing on the same day or within 3 days of those confirming with high-grade histology. This is the Dendo classification, and this is for the surgical morbidity or surgical outcome after the complication after the surgical for the surgery for the cases of the cancer. So grade 1, any deviation from the normal post-operative course without the need for pharmacological treatment or surgical endoscopic or radiological intervention. And grade 2 is requiring pharmacological treatment with drugs other than those permitted for grade 1 complication, such as the blood transfusion or total parenteral nutrition. The grade 3 requiring surgical or endoscopic or radiological intervention, and this is divided to A and B. A for the intervention not under general anesthesia, and B for the one intervention done under the general anesthesia. 3C is the severe form from B, and the stage 4 is or grade 4 is the life-threatening complication, including complication of the central nervous system that require management of high dependency or intensive therapy on it. And 4 is 4A, divided to 4A with the single organ dysfunction like the renal failure or something like this, which needs dialysis, or stage 4 with the multi-organ dysfunction, and 5 is the death following the surgery as a complication. So the data collection and method, it is a retrospective audit, was conducted for 82 patients. diagnosed and treat for the gynecological cancer within the Hywel Dam. And as I mentioned that from 22 to 23. And the data was meticulously collected from the various sources, including the clinical letters and surgical reports and notes. So the number of the surgical procedures was done for 69 patients, and the laparoscopy was in 55% of them, and the open surgery for 45%. And this represents a significant increase in the laparoscopic surgery from 22% in 2019 audit to 55% in 2022-2023. So this is the number of procedure and the number of the laparoscopy. So 8 cases had hysterectomy, and 50% of them done laparoscopically, and the ovarian staging procedure for hysterectomy, bilateral salpingioophorectomy, omentectomy, peritoneal wash, and lymph node biopsy and dissection for 44 cases, and 55% done through the laparoscopy. Debulking surgery, 8, and none of them done by laparoscopy. Total abdominal hysterectomy, bilateral salpingioophorectomy plus right hemicolectomy, 1 case, and none of them also laparoscopy. Laparoscopic oophorectomy, 1 case, and done laparoscopy. And regarding the excisional vulval biopsy, partial vulvectomy, wide vulval local excision, LITS, this all, and pelvic accentration with the ileal conduit, all of them done open. I mean that it was not laparoscopy, and the radical hysterectomy, 2 cases, and also it was done open surgery. So the site of cancer distribution, the uterine cancer consists about 47.4% from the cases, and the ovarian cancer 45%, the vulval cancer 3.8%, and the cervical also the same. About the surgical morbidity, the overall surgical morbidity in our cases was 14.63%, 12 out of 82 patients, and the benchmarking against the UK Oncology of Surgical Outcome and Complications database, the national guidance, the rate is 25.9%. So our unit's morbidity rate is significantly lower than the national average. And this was the complications from the surgery. We didn't detect any mortality case. And the bowel obstructions following the surgical management was in 3 cases, pleural effusion 2 cases, urinary fistula 2 cases, and sepsis in 1 case, incisional hernia 1 case also, and the recurrence within 1 year is 1 case, and lymphedema 2 cases detected after the surgery. So comparing the result with the against standards, the compliance with the diagnosis of the type of malignancy was 100%, and compliance with the staging of malignancy 82%. I mean that the staging, before the staging before the surgery, comparing with the staging following the surgical management. The compliance with the chemotherapy and radiotherapy, 100%, and patient received chemotherapy 30%, 24 out of the 82 cases, and patient receiving the radiotherapy 22%, they were 18 out of 82 cases. Regarding the performance comparison between the audit we did in 2019 with the audit in 2022, so the definite treatment interval, the 62-day rule compliance, dropped to 89% from 100%, and I will discuss in the next slide why this happened. The cancer stage diagnosis match, that the provisional versus the definitive improved to 82.3% from 75% in 2019. And definitely the laparoscopic surgery rate significantly increased from 22% in 2019 to 55% in 2022. As a conclusion, the performance of our unit, gynecological oncology surgery, is commendable with a surgical morbidity rate significantly below the national average. There has been a positive shift toward the minimally invasive surgery with the substantial increase in the laparoscopic procedure. Areas of attention include the slight decrease in compliance with the 62-day rule, and this was mainly due to the loss of one-stop clinic, especially for postmenopausal bleeding in endometrial cancer during the COVID pandemic. And hopefully this will be improved in the next audit, as we started a cancer improvement group weekly, and the patients now get scanned and have hysteroscopy on the same day. This is our team members shared in this audit. Thank you very much.
And so currently I'm working in UK as a specialty doctor. And so this is my first slide. Okay. So introduction. So preterm birth. Preterm delivery is defined as a birth of baby before 37 weeks of gestation, which is 259 days. Significance. Preterm delivery is a major contributor to infant morbidity and mortality, leading to complications such as respiratory distress syndrome and long-term developmental issues. So despite thorough investigations, preterm delivery continues to represent 5 to 10% of all births in affluent nations, and the rates are rising. Although the death rate linked to preterm delivery has decreased as a result of the use of corticosteroids and advancement in newborn intensive care, preterm infants continue to be vulnerable to significant problem. The condition encompasses respiratory distress syndrome, necrotizing enterocolitis, retinopathy of prematurity, sepsis, interventricular hemorrhage, periventricular leukemia, as well as long-term cognitive and sensory impairments. Gestation and delivery and birth weight are two primary factors that significantly impact the death and morbidity rates of preterm infants. The occurrence of premature births has substantial financial repercussions for both healthcare system and society as a whole. The occurrence of preterm birth is influenced by several factors. The study presents worldwide and local assessment of the frequency of preterm birth. The statistics are concerning. In 2005, a total of 13 million infants were born prematurely around the globe, with Africa and Asia accounting for 85% of these births, which mean around 11 million. Africa, North America, and Asia had the highest prevalence of preterm birth, with rates of 11.9, 10.6, and 9.1%. Approximately 75% of births are the result of spontaneous premature labor, while the remaining cases are due to intervention for maternal and fetal causes like preeclampsia, fetal growth restriction, maternal diabetes, placenta previa, or placental abruption. Preterm delivery is often associated with considerable morbidity, mortality, and attempts have been attempted to impede the process, operating under the idea that the greater the maturity of the fetus at the moment of birth, the more favorable the outcome for the newborn would be. Research has shown that there is an increase in survival rates from 8% at 23 weeks of pregnancy, with a daily improvement of 3% at this stage of gestation. Preterm birth has a complex origin and has been characterized as a syndrome involving various pathological processes such as uterine overdistension, ischemia, infection. Additional risk factors for preterm birth include cervical disease, endocrine disorders, intrauterine infection, cervical abnormalities, and uterine malformation. The Salmaniya Medical Complex is the leading tertiary care facility in the country of Bahrain, and it treats high-risk pregnancies, including those who are premature. Regardless, there is a deficiency of regional research examining the cause and consequences of preterm delivery. The purpose of this research was to identify a risk factor for preterm delivery and the frequency with which it occurs. This article presents the results for the research. So the objectives was of this cross-sectional study, which was carried in the Kingdom of Bahrain from January 2019 to June 2019, was to identify the risk factor associated with preterm delivery. The secondary objective was to assess the frequency of preterm birth at Salmaniya Medical Complex. The methodology used, it was a cross-sectional study. Duration, I have told, it is 6 months from January 2019 to June 2019. And sample size was 1289 pregnant women who delivered after 20 weeks of gestation. We excluded the patient discharged to other facilities or transfers in utero to other tertiary care hospital. So a data collection tool was incorporated. Characteristics of the participants, including their age, nationality, ethnicity, and occupation, factors that contribute to the likelihood of negative social outcomes, for example, tobacco use, consumption of alcohol, and the use of illegal substances. Obstetric history includes information about the type of pregnancy, how far along it is, any issues that has arisen, the outcome for the fetus, the weight of the fetus, and whether there are any congenital defects present. The data collected from each participant was added to an Excel spreadsheet. The Excel sheet contained patient characteristics, social risk factor, present obstetric history, previous obstetrical history, and medical history, as depicted in the figures. The data was detected during the analysis. The chi-square and Fisher exact test were utilized to compare categorical variables. So the results. According to the current study results, 1084 full-term births and 205 preterm births occurred out of 1289 patients. Present study results showed that maternal age had no significant difference in terms of preterm birth. Mean maternal age, with or without preterm birth, was 30.54 to 30.81 years. And parity status of mothers with preterm birth showed that were primigravida are 141 and were multigravida, while among other mother without preterm birth was 25%. So it is more prevalent in the primigravid with 68.78% than to multigravid, which was 25%. And the antenatal complications seen that they were higher among preterm deliveries, that is 24.9% versus 14%. The emergency cesarean section rate was also higher because mother who had preterm birth, among them, it was 49%, and with elective one is 51%. So maternal complications were seen in around 8.8% mother with preterm delivery. The most frequent conditions seen with mothers delivering preterm were hypothyroidism, diabetes, gestational diabetes, or diabetes or non-diabetic status, cardiac disease, and asthma are more common with the preterm ladies. Also, 8.8% of mother were preterm. I have experienced medical conditions like hypothyroidism or long-standing diabetes, and which was seen in 7.5% in mothers without preterm births. Implication: the maternal health plays a critical role in the outcomes for preterm delivery. So as we have seen that the more okay, so now I will go to the Okay, so there is a significant difference between the neonatal weight. It is the average weight in preterm fetuses is 2.23 kilograms compared to 3.1 average weight in term infants. And the delivery mode, spontaneous delivery was seen in 92.7% in preterm versus 98.5% in term. And emergency cesarean section were more common in preterm infants. So the conclusion now, so preterm birth is a prevalent issue at Salmaniya Medical Complex. Identified risk factors include gestational diabetes mellitus, premature rupture of membranes, pregnancy-induced hypertension, preeclampsia, antepartum hemorrhage. So addressing these factors after the study, we came to a conclusion that addressing these factors, diagnosing, properly treating, managing these conditions can reduce the risk of preterm birth in future. The results of the current study indicate that nulliparous women had a considerably greater incidence of preterm birth compared to both multiparous women. So, furthermore, some studies have demonstrated that a higher number of pregnancies is likely to elevate the likelihood of premature delivery as a result of uterine alterations, such as stretching of the myometrium from prior pregnancies. There was no correlation between the time between pregnancies and the occurrence of preterm birth. Okay. So recommendation derived from this study has led us to devise enhanced prenatal care, focus on high risk factors, focus on medical conditions which the patient entered in the pregnancy with, like hypothyroidism, high blood pressure, known hypertension, diabetes, and research initiatives. We found that conducting further studies to explore mechanism leading to preterm birth in these specific ladies. And community awareness also, which was not seen very evidently in that area, that educate expectant mothers on risk factors and on proper management of their chronic diseases and healthy practices, which can start in prenatal and can continue in antenatal period, and which can result in reduction of the preterm deliveries. So I'll just go through the conclusion. So preterm birth is a notable issue among women who gave birth at Salmaniya Medical Complex. Extended gestational diabetes, premature rupture of membranes, pregnancy-induced hypertension, and antepartum hemorrhage are distinct factors that contribute to preterm birth. Improving the management of these obstetric difficulties and doing research to understand the mechanism through which it has contributed to increase in the preterm birth can be a viable strategy for reducing the higher rates of preterm birth. Any questions?
In terms of the UK, the team leader, the lay board coordinator, is a senior midwife. That may vary in the country that you work in, but the research relates to the individual who coordinates the shift for the duration of the shift, so they coordinate the multidisciplinary team. So the reason I was interested in doing this research was I was a head of midwifery, noticed how doctors, midwives were very interested as to which coordinator was going to coordinate their shift, because they perceived that would influence how well the shift ran and also their stress levels. And I've also been party to women and mothers saying how the coordinator has made a difference to their care. So why is this role different? It's very different to providing clinical care that we do as midwives and doctors, and you need a very different skill set to manage staff, i.e. the multidisciplinary team. So the aim of the research was to explore the multidisciplinary perspectives of the lay board coordinator and the attributes which have a positive and negative influence on the function of their shift, team working, and individuals' confidence. So the research question is, what are the attributes in the labour ward coordinator that the MDT perceived to be important for the effective coordination of their shift? So what does the literature say? There's no literature at all on the labour ward coordinator. There's evidence from New Zealand, self-reporting labour ward coordinators to what they saw the role to be. There's evidence to say what makes a good midwife as a work colleague, and also from the woman's perspective. There's a lot of research to say the labour ward environment is incredibly stressful, so that's very important that we have good leadership. And it's also evidence to say that coordination of the labour ward is linked to good multidisciplinary team working. But for some reason, this role has been forgotten within the research. So basically, the labour ward is a stressful environment. There's work in the UK, and I'm sure this is the case in your countries, to say that it is a very stressful environment and contributes for a lot of burnout, which is why midwives leave the profession. And in the UK, 30% of doctors who would opt to go into obstetrics and gynecology choose to go to other specialties because of the stress in obstetrics. Stress also impacts on clinical excellence, and it has a direct correlation as to how satisfied staff feel with their shift. So if it's a very stressful shift, they feel very dissatisfied. So stress itself can impact on staff and women. We know if we're very stressed, our cognitive function, short-term memory and decision-making, and our ability to communicate is severely affected. There is evidence to say the labour ward is a gatekeeper in terms of whether staff are included or excluded, and they're very key to supporting staff transitioning to the labour ward. There's also evidence to say that if women perceive that the labour ward is very stressful, very busy, they will withhold information as they don't want to bother the busy health professionals. Within the UK, we have had significant amount of evidence to say that a history of poor MDT working, which has led to poor maternal and neonatal outcomes, have been directly linked with poor MDT working and human factors. And there are a number of strategies taking place in the UK at the moment to try and address these problems and improve safety for mothers and babies. So my research was 2 phases. I did logic modelling and thematic analysis of the labour ward coordinator role and the job descriptions, and then I interviewed members of the multidisciplinary team. You just bear with me, I just need to look at my notes because there's a box over some of these. So the thematic analysis of the job description said that the key functions of the labour ward coordinator was to coordinate the labour ward, leadership of the MDT, and staff development. The main part of my PhD study was interviews with obstetricians, so that was consultants, registrars and SHOs who are basically junior and new to the obstetric rotation. I also interviewed midwives, senior and junior, maternity care assistants and ward clerks. And in total, these individuals had experience of nearly 700 labour wards coordinators. I use constructive grounded theory as my methodology, and that is a process of where you simultaneously collect data, code, have memos, and constantly compare your data. And then this is done in parallel, so the information that you get from the first interview then feeds into subsequent interviews and the questions that you ask. So my findings, I developed a theoretical model of what makes an excellent delivery suite coordinator. I deliberately chose a triangle because if any of the sides are unstable or that aspect of the coordinator is missing, the labour ward becomes unstable and then that becomes unsafe for women. So let's look at these as separate entities. So the first thing that I found from all levels of staff was a really good coordinator is situationally aware. They have the helicopter view, not just of the labour ward, but the other wards that impact on maternity, for example, the postnatal ward area, the antenatal ward, any home births that are taking place. Now, Mika Ensley, who's done a significant amount of work within aviation, describes 3 levels of situational awareness, and I intend to present using her framework. Level 1 perception, level 2 comprehension, and level 3 projection. And you have to have level 1 before you can have level 2, etc. So labour ward coordinator who was seen to be excellent by the MDT was someone who knew what was happening with the women and the staff. They also had a very, very good understanding of their own staff's capabilities. Now, they maintain that helicopter view. You can see from this, I'm so sorry, there's a box over the words that's making, I'm so sorry. I've lost my presentation. Sorry, share, let me just try sharing again. I do beg your pardon. Can you see that now?
Yes, we can see it.
Thank you. So the registrars felt that the really excellent coordinators were the ones who had the overview of the communication board. I'm sure in your delivery suites you have a board where you have details of all the women that are on your unit, as also having a grasp of what was happening in the individual rooms. Consultants also felt it was really important that the coordinator had a good overarching helicopter view of the unit, and the midwife said that's what determined whether they were in control or not. And it was very much that the coordinators who were very proactive, they weren't in the office, they were leading on their feet, they were in and out of the delivery rooms, collecting the information. And what they did do when the unit became very busy, they would get the team together in a mini huddle to update, to make sure that they had the most current information. So how does a good coordinator operate at level 1? They're very proactive in collecting the information. They're always present at handovers. They don't get embroiled in clinical care. So they're always there at the board. So they have this helicopter view. And the thing was that the communications board was absolutely key. The excellent labour ward coordinators made sure that all that information was absolutely current. Level 2, the coordinators who were good at level 2, this is where they took all the information that they had and put it together, almost like assembling a jigsaw, so that they were able to create a shared understanding by the MDT of what was going on labour ward. This was particularly busy when the unit got very busy, and the really excellent coordinators wouldn't give a long, protracted history of the women. They were able to articulate to the consultant which women were a priority and which women were absolutely fine and didn't need reviewing. Interestingly, in health, we concentrate on our medical errors at level 2 in terms of our decision making as an MDT, but the airline industry understand that 70% of their errors occur at level 1. So if you don't have up-to-date information and you don't know exactly what's going on in your labour ward, you will make the incorrect decision making, which ultimately will affect mother and the neonates. Now, the excellent coordinators, the excellent coordinators were the ones who operated at level 3. These coordinators had the ability to project into the future. So that meant that, for example, they understood that everything was okay right now, but in 2 hours' time, they may have 3 women who are likely to have a caesarean section for lack of failure to progress, and they only had 1 theatre, so they had to make decisions based on forward projection, and this gave staff a huge amount of confidence that they were forward projecting and predicting to prevent accidents happening. Going back to supporting staff and decision making, consultants, registrars and the senior midwives valued the coordinators who bounced off ideas. So, for example, they had already made decisions, but they wanted to bounce off their ideas to make sure there weren't things that they were missing or anything else that needed to be added to the care. However, the more junior staff wanted to be guided by the labour ward coordinator, and these were a huge source of information and teaching, particular to the very junior doctors, as these midwives would call the doctors if, for example, they knew there was going to be a forceps delivery, so that they could get the training. The junior doctors also saw them as a huge source of information and experience from which they could learn. The coordinators were also very supportive to their junior staff, so they always allocated a more senior member of staff, so that if that junior member of staff had any particular questions about complex care, they had someone they could go to directly. Importantly, in human factors, we know that lack of nutrition affects decision making, and the excellent coordinators made sure that all their staff got breaks, particularly when the unit was busy. They understood that perhaps if a midwife or doctor wasn't around to have a break, that was probably because they were caught up in a room with a woman was very complex. And this is very important in terms of our cognitive ability. If we don't have glucose, our brains don't function correctly and we make mistakes. And they also were very good at allocating workload based on staff's experience. And the final component is linked to psychological safety and incivility. You may be aware of the work by Christine Porrath, who has actually found that incivility at work and people not being approachable has a significant impact on safety. It was really important that staff felt that they could approach the coordinator to ask questions, and that is really important from level 1, from a situational awareness perspective and decision making. If the coordinator doesn't have that information from the staff, he or she then doesn't have the overview of the labour ward to make clinical care decisions. It was also key to staff feeling positive about their shift. If they'd worked with an approachable coordinator, they went off their shift feeling really positive, as if they'd been heard. It reduced staff stress, and it was key to doctors learning. If they had an approachable coordinator, doctors said it was a fantastic vehicle to learn from. It was about that ability to ask questions and not feel silly. This junior midwife here and registrar, the SHO, explaining how their question may seem very trivial, but it was important to them, and that they could ask that question without being undermined. Okay, the impact of the coordinator not being approachable meant that midwives and doctors would not share information with the coordinator, which has an impact on safety. So they may withhold information that they wanted advice on, or they would go directly to another member of staff. This is very key, because if the coordinator doesn't have her staff, his or her staff, communicating with them, they are not party to being situationally aware of what's happening on the labour ward. I don't have time to go through this within this presentation, but these are the leadership styles that the excellent coordinators portrayed. In particular, emotional intelligence. And if you're not aware of that, I would strongly advise you to have a look. It's about how we are as individuals and how we understand us as individuals and how we impact on other people. So the highly intelligent coordinators were the coordinators that people wanted to work with. So the contribution to the literature, the labour ward coordinator role has a pivotal role in the management and leadership of their shift on labour ward. The role impacts on staff's contentedness and stress levels, which directly affect information sharing, situational awareness and clinical decision making, ultimately impacting on clinical safety for women and the newborn. So the recommendations for practice is that the labour ward coordinator should always be supernumerary, because if they get embroiled in clinical care, they lose the situational awareness that is necessary for a safe labour ward. If you are looking to recruit your labour ward, to include some form of assessment of a situation awareness at the interview. Secondment opportunities, there may be midwives or doctors who are interested in being coordinators, and giving them that secondment opportunity to see if this is an area of professional development they wish to pursue. In terms of education, current labour ward and aspiring labour ward coordinators should actually do a course which included human factors which includes situational awareness, and that is ongoing in the UK at the moment as a result of this research. Just a question to you all, how do you train your labour ward coordinators? Do they have specific training, or is it an assumption that because they're a good clinical clinician that they're capable of running a labour ward? Also, do you incorporate situational awareness in your undergraduate and mandatory training, and does that happen in your country? Also, are your coordinators given feedback on their emotional intelligence? Areas of further research, I found that we need to find out what makes a labour ward coordinator confident. What's the impact of the coordinator role on team working? Do we use succession planning and situational awareness in our succession planning, and what support is available for labour ward coordinators, because this is a very demanding job. I would just like to conclude, because we know a lot about situational awareness from the airline industry. Now, we can have the best doctors and midwives giving one-to-one clinical care, which I would suggest are the pilots. But if you don't have a situationally aware coordinator, which I would relate to the air traffic controller, you have real problems on your labour ward. So just a rhetorical question to you, how safe is your labour ward? Thank you for listening, and there are my contact details and the references for the presentation. I just wondered if there's any questions.
Going to present about predisposing factors and outcome of pregnancies with malpresentation in a tertiary care hospital, Bangladesh. Any presentation other than vertex is termed as malpresentation and includes breast, shoulder, face, brow, and compound presentation. Malpresentations are estimated to occur in 5% of all term deliveries. It is associated with an increased risk of maternal fetal morbidity as well as mortality. Maternal complications include pre-labor rupture of membranes, cord prolapse, increased risk of instrumental delivery, cesarean section, obstructed labor, and ruptured uterus. Fetal complications are low 5-minute Apgar score, meconium aspiration, hypoxic ischemic encephalopathy, but trauma. Perinatal mortality associated with vaginal breast delivery is more than thrice that of the vertex. Breast is the commonest malpresentation. The incidence of breast presentation at term 3 to 4%. Transverse lie is seen in 1 in 300 deliveries at term. Face presentation occurred in 1 in 500 deliveries, and incidence of brow presentation is 100 deliveries.
No problem. You're doing good. Good. Now you're able to walk and everything. You can attend it.
Of my studies to determine the incidence predisposing factors, maternal and perinatal outcomes of pregnancy with malpresentations, to formulate the preventive measures for reducing maternal and perinatal complications in patients with malpresentations. Methodology. This includes study design. My study was prospective observational, done in Department of Obstetrics and Gynecology at Chattogram Mao Shishu Hospital Medical College, Agrabad, Chattogram, Bangladesh. From January to December 2023, the total number of cases were 995. Now, inclusion criteria. All the women with malpresentation with or without medical and obstetrical complications and who had delivered in our hospital were included in this study. All the women with malpresentation more than 28 weeks of gestation. Exclusion criteria. Those malpresentation cases who were admitted for observation and discharge and did not come for follow-up. Gestational age less than 28 weeks. Results of my study. During the study period, total number of deliveries were 4,576. Number of deliveries of malpresentation during the same period were 195. Overall incidence of malpresentation cases were 4.3% of total deliveries. Table on shows distribution of the cases according to the type of malpresentation. Here, in my study, most of the malpresentation, breast presentation, that is 74.9%, followed by shoulder presentation, face, compound, and brow presentation. Table 2 shows demographic and obstetric profile of the patient. In my study, most of the patients were in the age group of 26 to 30 years. And most of the patients came from urban area, that is 55%. Now the gravidity. Maximum of the patient were primary gravida, that is 63.6%. And multiple pregnancy only 19.40%, and most of the patients are singleton pregnancy. Now gestational age. Maximum patient gestational age were 37 or more, that is term pregnancy or more. It includes 63.6%. And regarding antenatal visits, most of the cases were unbooked cases, that is 52.8%. Table 3 shows distribution of cases according to parity. In my study, primary gravid patient are maximum, and in this primary gravid patient having the breast presentation, and multigravid patient having most of the shoulder presentation followed by face, compound, and brow. Distribution according to type of the breast presentation in table 4, the frank breast are maximum cases, that is 52.73%, followed by complete breast and cooking breast. Distribution of the cases according to presentation in compound presentation. In case of compound presentation, head with hand were 66.7% and head with foot were 33.33%. This table shows the associated risk factors. There are a lot of predisposing factors for developing the malpresentation, that is prematurity, twins, multiparity, oligohydramnios, uterine anomalies like unicornuate uterus, bicornuate, subseptate, septate, contracted pelvis, polyhydramnios, placenta previa, hydrocephalus, cord around the neck, anencephaly, fetal ascites, fibroid uterus, intrauterine fetal death. Here, the risk factors are prematurity were the maximum, that is 36.41%, followed by multiparity, twin pregnancy, oligohydramnios. Now, distribution of the cases according to mode of delivery in table 7. In my study, the lower segment cesarean section occurred 80% and vaginal delivery 20%. Assisted vaginal delivery in my study was 22.63% and internal podalic version followed by breast extraction were 5.141%. দেখা যাচ্ছে না, এটা এদিকে দেওয়া যায় তো। একটু ছোট করা যায় না? Table 8 shows the maternal complications. Maternal complications include obstructed labor, followed by atonic postpartum hemorrhage, cervical tear, rupture uterus, penile tear, prepuce sepsis, post-cesarean wound infection. Here, maternal complications are maximum or obstructed labor, that is 6.2, followed by atonic PPs 3.1. Perinatal complications. There are a lot of perinatal complications, that is prematurity, low birth weight, perinatal asphyxia, respiratory distress syndrome, NICU admission, stillbirth, neonatal sepsis, neonatal jaundice, early neonatal death. Here, the maximum complication of the perinatal were prematurity, that is 36.41%, followed by low birth weight, 23.08%, and perinatal asphyxia, 13.33%. In my study, perinatal mortality was 5.8%, but there are no maternal mortality. Now, discussions. Malpresentation is commonly encountered obstetric problem and associated with poor maternal and perinatal outcomes. The incidence of malpresentation in present study was 4.3%, which is comparable to the findings of the studies reported by Shahin M. et al. This incidence is narrowable to my study, 4.8%. Table 10 shows the comparison of type of malpresentation with different studies. In my study, the bliss presentation 74.9%, which is near to the Shruti S. et al., Smriti M. et al., but higher than the Shahin M. et al. And this is another malpresentation also comparable with their studies. Table 11. Comparison of mode of delivery with different studies. In my study, cesarean section was 80%. This is near to the study of Smriti M. et al. And Shahin M. et al., but higher than the Shruti S. et al. In my study, vaginal delivery only 20%, which is higher than the Smriti M. et al., Shahin M. et al., but much lower than the Shruti S. et al. Table 13, comparison of maternal complication with other study. Here, the most important maternal complication of obstructed liver, atonic PPs, in my study, it was 6.2%, 3.6%, and also the other complication are comparable and near to the complication of the study of Shruti S. et al. Table 3 shows comparison of perinatal complication with different studies. That is, prematurity. In my study, the prematurity was 36.41%, and in case of study of Shruti S. et al., 36.61%. Low birth weight in my study 23.07%. It was much lower than the study of Smriti M. et al. And higher than the Shahin M. et al. And other complication also comparable with these three studies. Now, conclusions. Malpresentation is associated with significant maternal and perinatal morbidity as well as perinatal mortality, which could be reduced by preconceptional counseling, regular antenatal care, early detection, and early referral to higher centers. Delivery should be planned at centers which have expertise in conducting vaginal delivery in malpresentation with good interpartum monitoring and with facilities for cesarean section and NICU for the better maternal and perinatal outcome. Thank you for all for patience hearing, and a special thanks to the organizing committee for giving me such opportunity for presenting here.
Thank you, Dr. Yasmin, for the exceptional presentation. So any questions from the audience side?
Hello, dear colleagues. Thanks a lot to the organizers for the invitation and opportunity to take part in your Congress. It is a great pleasure for me to present you the report. An early pregnancy loss is one of the most common complications. A non-developing pregnancy, the most common form of an early pregnancy loss, is characterized by the death of an embryo or a fetus without symptoms, or expulsion of the products of conception, and accounts for a half of all first trimester miscarriages, according to the American Pregnancy Association. Besides psychological discomfort, which in 18% of cases is developed as post-traumatic stress, in 17% as moderate or severe anxiety, and in 6% can take on the character of severe depression, early pregnancy losses have extremely negative consequences for subsequent pregnancies, childbirth, and the postpartum period. The structure of early pregnancy losses is currently well known and is conventionally divided into 7 categories: genetic, immunological, and infectious causes, disruption of desidualization and implantation processes, anatomical abnormalities of the uterus, and the most difficult category to control, somatic diseases of a mother. And among all the factors that lead to early pregnancy losses, some will be predisposing ones, while others will be resolving ones. Researchers of the recent years have shown that oxidative stress can become a trigger mechanism in the development of pregnancy complications. Over the past decade, the topic of oxidative stress has become more relevant, and the knowledge on this subject has been expanded. The number of publications on the topic of oxidative stress is also growing exponentially, including in obstetrics and gynecology. Redox balance is vital for both individual cells and the body as a whole. Reactive oxygen species are products of incomplete reduction of oxygen molecules by the body. Under physiological conditions, an increase in the level of reactive oxygen species is necessary for normal development of the placenta. Cellular oxidants participate in maintaining the redox homeostasis, regulate the immune response, activate proliferative pathways, and apoptosis. However, when antioxidant protection is reduced, they oxidize fats, proteins, and DNA, and thus can contribute to tissue damage. Toxic products of the oxidation reaction have a cytostatic effect on the cell, damage cell membranes, and activate apoptosis mechanisms. Uncontrolled elevated levels of reactive oxygen species and/or reactive nitrogen species, or a decrease in antioxidant defense, can lead to an oxidative stress. Oxidative stress is considered to be in the pathogenesis of a number of diseases of the female reproductive system, such as endometriosis, polycystic ovary syndrome, infertility, preeclampsia. At the end of the first trimester, when the placenta is fully formed, there is a threefold increase in oxygen concentration, which leads to increased levels of reactive oxygen species, mainly in the syncytial trophoblast. Under physiological conditions, these processes are tightly controlled by the body as a result of enzymatic, non-enzymatic antioxidants. The purpose of the study is to assess the state of the pro-oxidant and antioxidant system in endometrial tissues in order to provide a differentiated approach to an antioxidant therapy in women with a history of a non-developing pregnancy at the stage of pregravid preparation. A study of 46 women has been conducted, of which 21 patients with a history of non-developing pregnancy made up the main group of the study. The control group included 25 women without reproductive losses who had applied for a pregravid preparation. Patients with severe extragenital diseases, endocrine pathology, a uterine miscarriage factor, an antiphospholipid syndrome, and congenital thrombophilias in the medical history, a confirmed pathological karyotype of a fetus, pregnancy as a result of IVF were excluded from the study. The following ones were studied: biological fluids, blood serum, and metroaspirate obtained from the uterine cavity, as well as chorionic tissues in which markers of oxidative stress were being studied. Malonyl-dialdehyde, a marker of lipid membrane oxidation, carbonyl groups of proteins and protein oxidation products, superoxide dismutase, an antioxidant of the primary link of antioxidant protection, and a nuclear factor erythroid 2, a related factor 2 protein. The results of the anamnestic data study are presented to your attention. In patients with a non-developing pregnancy, in the anamnesis, chronic diseases and tumors of the reproductive system are statistically more often noted. The results of the study of the markers of the oxidative stress are presented in the table. The results of the study have shown that the level of oxidative stress markers in endometrial tissues in patients with a fetal loss in the anamnesis was statistically higher than in the control group. An imbalance of ascorbic acid can affect the concentration of ferrum 2+ and its pro-oxidative effect on unsaturated fatty acids in the biological membranes. In patients with fetal losses in the anamnesis, the activity of ascorbate-dependent LPO processes in the endometrium, where ascorbic acid is a powerful inducer, was significantly higher than in the control group. The disturbance of pro-oxidant-antioxidant balance towards the oxidative stress in the study group is also evidenced by the increased level of superoxide dismutase in the endometrial tissues, one of the main endogenous enzymes of the first line of antioxidant defense. Thus, in the tissues of the endometrium of patients who had fetal losses, there are shifts towards an increase in the level of pro-oxidants. Based on the obtained results, a method for determining indications for prescribing an antioxidant therapy for a miscarriage at the pregravid stage is proposed. The method is that in the endometrial tissues obtained by a pipal biopsy on the 16th-18th day of the menstrual cycle, the level of malondialdehyde is determined in the spontaneous, enzymatic, and non-enzymatic reaction of lipid peroxidation. And the activity index of superoxide dismutase with the level of malondialdehyde in the spontaneous reaction of lipid peroxidation of at least 5.72 nanomole per hour, in the enzymatic reaction of lipid peroxidation of at least 4.61 nanomole per hour, in the non-enzymatic reaction of lipid peroxidation of at least 13.56 nanomole per hour, the activity index of superoxide dismutase of at least 121.5 nanograms milliliters, the prescription of an antioxidant therapy is indicated. The results of previous studies, as well as the data obtained in the course of our work, support the concept that oxidative stress and mediated oxidative damage are important in the etiopathogenesis of an early pregnancy loss, and antioxidants are of a decisive importance for maintaining a pregnancy and maintaining reproductive health in oxidative stress conditions. The study of changes in expression, cellular and molecular mechanisms of antioxidant regulation is necessary for a correct understanding of the process of an antioxidant protection of cells from oxidative stress. Further clinical, experimental, as well as pharmacological studies devoted to an in-depth study of antioxidants will allow to expand the understanding of the potential use of an antioxidant therapy and its role in the prevention and treatment of pregnancy complications already at the stage of a preconception preparation in order to improve reproductive outcomes.
And how they are interpreting them and analyzing them. So can we go to the next slide, please? Thank you. So the objective of this study was to review the outline of core principles of digital pathology and AI in histopathology image analysis. I'm going to talk about it a little more if you don't have a lot of background about the image analysis and different AI algorithms which are now being used for the analysis of images of the digitalized slides. And we're specifically are going to talk about the gynecological cancer pathology and discuss different challenges that is now being faced using these AI methods in clinical practice. Can we go to the next slide, please? And also then the next one, because it's just the introduction. So as we know, gynecological cancers, like the ovarian cancer, endometrial cancer, and the cervical cancer, has a global health burden due to its high incidence and poor prognosis and frequent recurrence after treatments. And despite all the advances in imaging, still histopathological evaluation remains essential, and we still have a rising rate of cancer, and we're facing a lot of problems in terms of workloads and the number of staff, shortage of number of staff and pathologists to actually do these, to report the samples of patients. So artificial intelligence and particularly deep learning, I'll talk about it a little more, what is exactly deep learning. They're offering some solutions to improving cancer detection and classification and prognosis and also treatment prediction. This is used for different cancer types, which including the ovarian cancers, endometrial or cervical cancers. So these can help the histopathologist to have better clinical decision making, and it can help to improve the pace of the job which is being done. While we have the shortage of histopathologists, we can work with AI so they can help to do these different steps a bit kind of, let's say, faster. Can we go to the next slide, please? And then the next. So I've had this graph from one of the studies which was very thoughtful, and I wrote the reference in beyond the picture. So it's very good to have an overview of when all this artificial intelligence has been introduced to the world. So it was 1956 when artificial intelligence was first kind of launched, and then it was machine learning, which was let's say there are some of the algorithms which are used in artificial intelligence, and it was launched in 1959. And then it has deep learning. Well, deep learning is one step forward to machine learning. It's kind of bringing a more process to machine learning, make it more smart. And this one was launched in 1986. As you see, there is a gap in between because basically deep learning is worked based on central neural networks. And so it's a bit, it takes time to improve something like that. And then in 1990, we have whole slide scanners, which they were introduced. Traditionally, and even still in most of the centers, sorry, they have samples. They the samples and they see them under the microscope. But then after the introduction of scanners, now in many centers, they have specific scanners, so they kind of scan the slides with very high resolution, and that we call it whole slide imaging, so that histopathologists, apart from looking at the slides under microscope, they have this opportunity to see them also on their own computer. And so this is actually done with these scanners. And then we have the design of CNNs using the deep learning algorithms for the image analysis. So after having digitalized samples, then we can kind of run some algorithms based on AI on these images. And so in 1998, it was the first time that they were running these things. And then it was about generative adversarial networks, which were using two simultaneous neural networks, this one is done in 2014. And so finally in 2018, the first AI medical device was permitted by FDA. So before that, all these, let's say, algorithms were kind of used to just like for researchers and to see if they're working or not. So the first one, which is now being approved by FDA, was actually happened a few years ago. Can we go to the next slide, please? Okay, now we are going to talk about specifically this gynecological cancers. So I just named some of the models and algorithms which were used in the studies that I used in my review, just to hear them and to kind of, if you don't have any background of this, you can hear some of these words. So we have some models in machine learning, which we call it ML models, and mostly the algorithms which were used were RF, GBDT, DT, SVM, LR, MB, and KNN. You can see the abbreviations below, or you can also take a screenshot if you want to know it for the future. And then we have deep learning models. As I said, deep learning is a bit more smarter than machine learning. So the algorithms are CNN, which means central neural network, CLAM, and SVM. So this is particularly important because further in the slides, I'm going to talk about some of the studies, and I say which one used which of the algorithms. Then you have this kind of background about what is these algorithms exactly and what are these abbreviations that I'm using them. So the whole study, as just to give you a structure, is that I reviewed those actually researchers which use different algorithms in deep learning or machine learning, and then I categorized them, which one used deep learning, which one used machine learning, and which algorithms they each has used, and then in what part of actually diagnosis, prognosis, or in which field they have used them, which is related to gynecology. So can we go to the next slide, please? Okay, so it was about 27 researchers which were included in the review, and so one of the first thing which was used in these most of these actually researchers was subtype classification. So in subtype classification, we have it in ovarian cancer, endometrial cancer, and cervical cancer. In ovarian cancer, in one study, the usage of this actually SVM algorithms for subtyping of ovarian cancers shows an accuracy of 90%. Also, in another study, it shows which they employed deep learning methods of central neural networks based on AlexNet. It shows accuracy of 90% for both, cell level classification of both tumor and stroma cells. And also there was another study which they use, again, deep learning methods and central neural networks, and they have a diagnostic concordance of 81% in the training set and the external set for classifying ovarian cancer subtypes. In the endometrial cancers of the studies, there was a study which the error on the curve, it was kind of the statistical analysis they've used. They use area on the curve, which shows 96% for differentiating sample into endometrioid or serous histological subtypes. And also, on the other hand, the other model of Inception V3 shows area on the curve of 94%, classifying endometrial cancers. Then in cervical cancers, there was a study which employed AlexNet as the algorithm, VGG, and Exception, and ResNet, and it shows an area on the curve for internal validation from about 73% to 98%. And there was also another study which it used the efficient net B0 algorithms and for the classification of cervical cancers, and the result was actually showing accuracy of 94%. So well, actually, in all of these studies, they used an algorithms and they used the histopathologist's opinion, and then so from this they can actually kind of calculate the accuracy of the algorithms and how it works. Then can we go to the next slide, please? So another domain which was used, which these AI methods were used, were prognosis and diagnosis of these three cancers. So in terms of ovarian cancer, for the diagnosis, in one study, they use Inception V3 model for the detection of malignancy on tissue slides. And it shows area on the curve of about 73% and 71% to 91%. And they use different, some studies use different models, so they can compare different models in their accuracy. So in also in it was another study that for ovarian cancer diagnosis with lamine-induced morphological changes of the nuclei as the input parameter. It used 99% of kind of area on the curve, which was very high as a validation set. And then also in the prognosis of ovarian cancers, they were, so the prognosis is basically something a bit more complex because it depends on different factors. But in one study, they use kind of by differentiation between epithelial and stromal regions in H&E stained histological images. They used deep learning CNNs like AlexNet, Places 345, and GoogleNet, and they extracted neutral image features. And so they have an accuracy of 90.2%. And which was a very good number. And also there were two other studies which used other different algorithms, and they both also shows an accuracy of around 90%. Then in endometrial cancers, in terms of diagnosis, there was a study which used CLAM, as you know, it was one of those methods, and they show an accuracy of 85%. And in terms of prognosis of endometrial cancer, there was also it was the data was used from Portec, and it was the predictive and it aimed to predict progression in 5 years, and so it was also showing very good accuracy. Also in cervical cancers, models which were used were central neural networks and SVM algorithms, and they were able to predict the 4 lesion classes at the patch level, and also SVM was used to predict the final slide level lesion status. For the prognosis of cervical cancers, it was a study which developed a CNN-based pathological risk score to predict patient prognosis, and they show area on the curve of about 80% for predicting both for predicting the cervical cancers. There was also use of these AI methods for cancer therapeutic response and microenvironments. So can we go to the next slide, please? Okay, this is a very good kind of, let's say, a smart chart which shows different studies have used I mean, in what percent they've used different algorithms. As you see for diagnosis, only deep learning algorithms were used. For prognosis, it was deep learning algorithms as well as the machine learning. And for subtype classifications, kind of both of the algorithms were used. And most of the usage was in diagnosis, subtype classification, and prognosis, so that we have fewer studies to actually use these deep learning or machine learnings in cancer microenvironments or therapeutic responses. So there is a, let's say, there's a scope of there is a space that can be filled by future researchers if there are more researchers who do studies on these topics. So can we go to the next slide, please? And also the next one, please. Okay, so while as I was kind of talk about it now, it gives a positive impact of using of this AI and machine learning and deep learning, but there are always some limitations and challenges regarding usage of these AI methods. So one of them is the data quality. So it's very important that the quality of data is really kind of influenced by scanners and resolution of the scanner. So it's very important that the higher the resolution is, then there's a better focus on specific biological elements by these deep learning and machine learning image analysis methods. So we always have this problem as in different laboratories, there are different scanners and they have different resolutions. Another thing is the validation of AI algorithms. So external validation is often lacking due to the difficulty in acquiring data. And AI algorithms have some limitation in specific domains, for example, like mutation detection, and their performance is typically lower in these parts. And then it's also about interpretability, that so despite the robust capabilities of AI-based models, the development of explainable AI models is imperative for clinical practice. And so some visualization methods have been developed to improve interpretability, but on the other hand, the integration of algorithms with other patient data, such as follow-up and clinical pathological information, has also contributed to improving the interpretability to a certain extent. So it still needs some more, there are some challenges regarding the interpretability as well. So can we go to the next slide, please? And then the next as well. So, so this review highlights how AI-powered digital pathology is being applied to improve the diagnosis, classification, prognosis, and treatment response assessment of gynecological cancers. So deep learning, especially the CNN's convolutional neural networks, shows a strong performance in these tasks, but the challenges like data quality, interpretability, and validation still remains. And while some areas like biomarker detection and multi-center studies are still limited, ongoing AI advancement and future large-scale clinical trials are expected to expand its clinical use. Thank you. So we can go to the last slide. Thank you for your attention, and thank you from the organization. And sorry if it becomes very long.
Thank you so much, Dr.
Can we go
Nirmala,
to
for the
thank you.
So any question?